to talk about this first trauma-informed principle of safety as it relates to group psychotherapy. And to begin that conversation, I think we have to start at the beginning. Before we start a psychotherapy group, first we have to consider our screening and assessment process, our pre-group selection process, as it relates to that group. Irving Yalom has a quote in his book. He's one of the most famous group psychotherapists. He says that good group therapy begins with good client selection. Clients improperly assigned to a therapy group are unlikely to benefit from their therapy experience. So, this really rings true in my experience as a group therapist and as an organizational leader and director of a group therapy program and inpatient, that one of the primary factors that leads to successful therapy groups is thorough pre-group screening and assessment. And one of the primary things that leads to unsuccessful groups or very chaotic groups or conflict that's difficult to resolve in groups or retraumatization in groups or just simple dissatisfaction in groups is when we really do a sloppy job of pre-group screening and assessment. So this pre-group screening and assessment really promotes a sense of safety for the individual that we're screening, but also for the rest of the group. Safety is threatened when an agency or group worker accepts a client to a group who really needs a different level of care or a different type of group treatment. Groups function best when there's some sort of overlap between the individual goals and experience and the collective goal and experience. And one of the things that I think is especially important in assessing appropriateness for a group that doesn't get talked about enough is that we're bringing together a collection of individuals, and we need to assess that their window of tolerance is somewhat similar. That if we have a bunch of people in a group who have a really wide window of tolerance and they have lots of coping skills and they're able to tolerate difficult emotions, and they've already done some of the early stages of trauma recovery and they're ready to go into trauma processing. But we also have others in the group who have a much thinner window of tolerance, and they might not have coping skills on board yet. They might not have internal ego strength and internal resources that they've cultivated, and they're in an earlier phase in their trauma recovery. It can really lead to incongruence in where the group is at in their recovery process, and it can make it difficult for us as the facilitator to meet all the needs of each individual in the group. And that some people are ready to go deeper into trauma processing, while others are really not ready to do that or be in the room while other people are doing that. And other people with a thinner window of tolerance might need more of the foundational trauma recovery skills, psychoeducation, coping strategies, strength-based work, whereas others in the group may have already spent weeks and months and years doing that, and they might get bored by redoing that again for too long. So we really want to assess each person's window of tolerance and try to put together a group where there's lots of overlap and similarities in the size and threshold of one's window of tolerance. Also helps to consider where each person's at in their recovery process from trauma. If we have a bunch of people that are brand new to trauma recovery, and we put them in a group with a bunch of people that are in phase 2, ready to do trauma processing, or even phase 3, where they've done some trauma processing and they're really ready to do that integrative work and focus on growing from trauma, meaning making, it really limits our ability to meet everybody's needs. It helps as much as possible to put together groups where people are all somewhat in a similar level, some similar phase of trauma recovery. And so what I'm referring here to is the 3 different phases of most clinical maps for trauma work. And there's a whole nother video focused on this channel that I encourage you to check out. But just a simple overview, phase 1 is about safety, strengths, coping skills, psychoeducation. Phase 2 in trauma therapy is about trauma processing, about working with defenses, protector parts, about dealing with the rage and the grief and the despair and the harm, the memories. And phase three is about transformation, about post traumatic growth, about integration and meaning making. So these are the three phases of the clinical map for safely working with trauma. Some general criteria that I find helpful in screening for trauma therapy groups in general, and especially psychodrama groups, are the following: willingness to engage in trauma work, psychiatric stability, suicidality, psychotic symptoms, medications, emotional containment skills, and the ability to tolerate discomfort, behavioral containment skills, so we can ensure that this individual isn't going to disrupt the sense of safety for the rest of the group and other participants in the group. Frequency or severity of drug use and alcohol use or other process addictions or behavioral addictions, the level of social support that an individual has in their life in terms of family or friends, an individual therapist, community support, peer support groups, and other support services, the expected length of time that the individual is going to be in treatment. I think this is especially important for inpatient groups where somebody might only be an inpatient for 2 or 3 weeks. Does it make sense for us to put them into a trauma therapy group in inpatient if we know up front that their insurance is going to cut them off a week from now? Probably not. But if we know that they're going to be in treatment for 3 or 4 weeks, or based on our best guess, considering the medical criteria they're presenting with and the insurance policy that they have, we could expect that they're probably going to be in treatment for 2, 3, 4 weeks. That would make a little more sense to put them into a trauma group where we can open some things up, but also have time to integrate and close up what we've opened before they have to discharge. We also want to know about their ability to continue trauma therapy at the next level of care. So if we know that somebody's about to lose their insurance coverage, maybe it doesn't make sense for them to start trauma therapy for 2 weeks while they're an inpatient, knowing that they're not going to be able to continue treatment when they leave. It also helps to have some congruence between the individual's presenting symptoms, their issues that are important to them, their goals for treatment, and the larger group as a whole goals and issues that are going to be addressed. So these are really meant to be guidelines, just things that I found helpful in my work in assessing for trauma therapy groups specifically and psychodrama groups. And these are going to need to be adapted for each agency and for different levels of care and different treatment settings. Again, Yalom suggests that the majority of clinicians do not select for groups therapy. Instead, they deselect who's going to be appropriate for group therapy. So it's really important that we not only have inclusionary criteria and we have a sense of who we're going to include in this group, but also that we have some exclusionary criteria. Who are we going to exclude from this group for their own safety and for the safety of the rest of the group? Who's not a good fit for this group? Now, many of us, as helping professionals, we got into this field because we want to help as many people as we can. And we might have a tendency or an inclination to want to include everyone, regardless of where they're at in all of our groups. And yeah, this might be a good intention, but I found that it really doesn't work well unless you're going to do more of a phase 1 type of group that's focused on coping skills and psychoeducation and group cohesion and relationships, safety, and you're not going to get into heavy trauma processing. If you're going to get into heavier work and trauma processing and rage and despair and really get into the depths of pain with clients and their trauma, then we need to have more exclusionary criteria. So I really encourage us to consider this in our pre-group selection process. Now, we also need to think about group rules and group norms. In many ways, our group norms and rules provide the containment or the structure for safety and the expectations for participation in the group. Now, there's lots of simple group rules that we can implement to promote a sense of safety for trauma survivors within our therapy groups, including commitments to confidentiality, which most of us probably already use, commitments to mutual respect. And another commitment I like to use, another rule I use in my trauma therapy groups, is a commitment to ask permission before engaging in any kind of physical touch more than a handshake or a fist pound. That because trauma often leaves us with our nervous system being on edge or hyper aroused, and so many people experience trauma because of inappropriate or violent physical touch. When that's really up for people in therapy, it can really be activating to experience unwanted or unexpected physical touch, a hand on the shoulder or a hug. And so, in all of my trauma therapy groups, I have some sort of rule about asking permission for physical touch. So, these are three rules that I use in pretty much any of my trauma therapy groups or more involved experiential therapy trainings as well. Other rules are going to be important to include depending on your group and your treatment setting. Like, for example, there might be rules in your agency that you have to also enforce, or there might be other rules about, like in an outpatient setting, you might have to have rules about people using their phone or silencing their phones during the group. Or in an inpatient setting, there might be other rules related to identification of clients being visible at all times, or food or drinks in the group room. These rules are going to vary from organization to organization. Other rules and agreements might relate to attendance and timeliness, being there on time, rules related to the financial aspect and payment for the group, and even other dual roles in the group. Dual roles in the group. So we might need to create a rule about group members having contact in between group settings. And many group therapists will have a rule for their outpatient groups that individuals are expected not to talk to each other in between sessions or exchange phone numbers. Other group therapists, depending on the populations they're working with and the settings that they're working in, opt not to enforce that role or create that rule for their groups. As someone that's participated in therapy groups myself and facilitated outpatient and inpatient groups, I actually find that there's a lot of value to the relationships that are formed within the group and how those relationships can be a source of mutual aid and peer support in between group therapy sessions. So I don't include that in my rules. If I was working with different populations, I might include that in my group rules. It also helps to have norms related to choice within the group process, especially if we're doing trauma therapy groups. Anytime I'm doing trauma therapy, one of the first things I do is I affirm each client's right to choose how much they want to disclose and when and how, to disclose their trauma in a general way, in a specific way, to observe for some time before participating in the group, to choose not to share in the group, to choose how much they want to be involved. And that's really about safety. That if we're forcing people to do trauma therapy and to talk about their trauma, that's not going to be helpful, and it's potentially going to be harmful. It can help to have a norm related to telling war stories about trauma. I always say at the beginning of my inpatient trauma therapy groups that this isn't a place where we're just going to sit in a circle and tell war stories about trauma. That's probably not going to be helpful. Might be re-traumatizing for folks, might be vicariously traumatizing for others. And just retelling the trauma story again and again and again without doing the other important work might just be strengthening the neural pathways related to that trauma memory and associations attached to it. So I always have some sort of norm related to telling war stories about trauma, that there's a place for telling the story and the details of the trauma. And when we get to that, there'll be a structure and containment for it. And I'll be really explicit with the group about, all right, now the prompt is, I want you to share one thing you're ready to talk about as it relates to a loss you experienced or trauma. I'll have a really specific prompt in a group setting when we get into details of the trauma. And that helps contain things. It can really help to have some sort of ritual for each group session about reaffirming and recommitting to group rules and group norms. So in my groups, what I do is whenever there's new group members, I spend a bit more time talking about the different group norms and the group rules. When I have a session and there's not any new group members, I very quickly go over the group rules and I ask everybody to commit to them, regardless of if there's new people or not. The method I like to use to have people commit to the rules when I'm doing experiential groups in psychodrama is I outline the rules and I say, if you're willing to commit to these rules today, stand up. And what happens is everybody stands up. We get to quickly look around the room and visually see everybody's embodiment of their commitment to these rules. And now everybody's out of their chairs, and I can quickly go right into an experiential warm up, some sociometry, or a psychodrama warm up. As pretty much every group I'm running, most of the groups I'm running are experiential or psychodrama groups specifically. And when we're doing experiential work, usually the hardest thing to do is to get people out of their chairs initially. So doing it through the group commitment to the rules and norms kind of makes it a bit easier. Of course, if there were folks with physical limitations about standing up, or I had group members that were using a wheelchair, obviously I would modify that so that everybody could participate in it. What often happens in terms of enforcing group rules and norms is that early on in the group development process, the group leader ends up doing most of the maintaining of group rules and group norms, of enforcing them, reminding group members about them, holding group members accountable. But as that group goes on, what inevitably starts to happen is that the longer term group members start really enforcing and maintaining the rules and the norms with other group members. And that I want to say the responsibility of it, but the frequency that the group leader has to enforce the rules tends to decrease as other group members take accountability and responsibility and ownership of the group and naturally start to enforce these rules with their peers. So, in terms of safety in group therapy, it's helpful to think about the physical layout of the room, as it can really impact the sense of safety and comfort for participants. So this means considering the furniture, considering the decorations within the room, considering the layout of the room. Are the exits clearly marked? Are the exits blocked? Like if we put the chairs in a circle in the group room, we need to make sure we do it in a way that individuals can still get to the exits if there's an emergency. I found throughout my career that many trauma survivors don't feel safe sitting with their back to the door. So I try to set up my group room in a way that it's generally in a circle of sorts, but with no chairs with the back to the door. Or if I'm forced to put a chair with the back to the door, I claim that as my chair so that nobody else in the group feels like they have to sit with their back to the door. It really helps to use a circle of sorts instead of more of a lecture style setup within the group room, in that it provides a visual kind of symbolism that everybody has an equal place in a circle. Whereas a lecture style where everyone's facing the facilitator is more of a hierarchical group structure. So it helps to put the chairs in a circle of sorts. Now we need to make sure that there's privacy and that there's confidentiality within the group room, that the sound isn't carrying into the adjacent rooms or hallways, that the doors are closed, windows are closed, and that there's shades on doors or windows if necessary. We also might have to consider the organization's relationship to the group and the group's place within the organization. I think this is maybe less relevant in outpatient settings, but more relevant in higher levels of care. In my inpatient group, for example, when we first started the group, it was really common for other staff members to pull patients out of whatever group they were in to sign a release form or to make a phone call with their case manager or their therapist, or to go take vitamins or medications that they forgot to take that morning, or to meet with another professional on the team. And that might be necessary on some level in inpatient settings and higher levels of care. But in facilitating a trauma therapy group, I found that to be really disruptive for the safety of individuals within the group. That if we're in the middle of some sort of trauma processing exercise and one of the nurses knocks on the door and opens the door and says, "Hey, I need to take Johnny. He needs to come get his medications." And we're right in the middle of somebody telling their trauma story or expressing anger or grief. It really disrupts the containment of the group and the safety of the group. So I had to advocate within the agency that it was not clinical best practice to be disrupting a trauma therapy group midway for any reason unless there's an emergency. And that's been the norm within the agency ever since. So you might have to advocate within your agency, create conditions and a container for safety in the groups that you're facilitating. This reminds me of one of social work's theories, the two-client system. Larry Shulman talks a lot about this, that as social workers, we really have two clients. The group is our client, and the agency, the system that we're working in, is our other client. And we have to actively work to create change within both the group and within the agency and system. In terms of disruptions, it also helps to have norms related to using the bathroom or stepping out of the group or using phones or anything else that would distract people so that you can really hold the container of the group. In group therapy, safety is also largely related to group cohesion and related to the matrix of relationships and connections within that group. So safety is often a prerequisite for social engagement, according to polyvagal theory and Stephen Porges' work. So we really have to cultivate safety in order to cultivate meaningful connections. And we also use our relationships to cultivate safety. So there's sort of a reciprocity there between connection and safety. Other experts in the field, such as Gabor Mate, have even suggested that safety is not so much about the lack of threat, but more so about the presence of human connection and emotional attunement within a relationship or within a group. So this is a really interesting way of shifting how we're thinking about safety, that it's less about disruption to safety or the absence of threat or violence or harm, and more so about the presence of connection and attunement. Now, many of the folks that we're working with in group work have been harmed in relationships, in groups, and in community or social settings. And so it makes sense if the nature of the trauma is relational or group or community related, that the healing from that trauma would also have to take place within a group, community, or relational context. And because so much of trauma happens because of other humans in relationships, I really find group therapy to be uniquely positioned and situated to help heal relational trauma. Trauma so frequently leaves us feeling a sense of mistrust, shame, and isolation. And group work is unique in that it provides correction through authenticity, through the normalization of experiences within the group, through the emotional support and peer support, and a sense of shared experience. I'm not the only one that's been through this trauma, this adversity, this experience of loss. When there's strong cohesion within the group, it will naturally lead to the embodiment of trauma-informed principles between the group members, that they'll be contributing to a sense of safety, a sense of trustworthiness and transparency, empowerment and peer support and mutuality and respect, voice and choice, and addressing issues related to identity. So cohesiveness is really related to trauma-informed principles. In the early phases of group development, the participants in the group are primarily going to be connected to the group leader. And so that therapeutic relationship is going to be especially important in the early phase of group development. And part of the leader's task and responsibility is really to develop that therapeutic relationship and a connection to each individual within that group. As the group goes on and moves through the different developmental group processes. And there's a whole nother video on this channel that outlines those phases. A simple way to think about it is beginning, middle, and end phases. As we get into the middle and ending phases of the group, the relationship with the therapist perhaps becomes less important and less central, and instead the relationship between participants in the group becomes more and more important. Early on, the facilitator is often a role model for how others are going to interact with each other. One of my mentors, Larry Shulman, he often says, more is caught than taught. And this is true for us as educators and also for us as group facilitators, that our clients are constantly watching us and mirroring and reflecting and mimicking the things that we say, the behaviors that we're engaging in, and the ways that we're relating to others. So more is caught than taught. Some participants in a group might feel safer with a therapist than they will with other group members, but others are going to feel safer with their peers than they're going to feel with a group leader. There's lots of different ways we can promote safety in our relationship with group members. Sometimes our identity and sharing, being transparent about our experiences or our identities, our social location, our culture, it's going to be really important for group members to feel safe. Another important aspect is our nonverbal communication. What's our voice tone that we're using, our posture, our gestures? Are we engaging in physical contact with our group members, and how? Our personal disclosures and the level of vulnerability and transparency that we demonstrate can really help cultivate a sense of safety within our relationship with our group members. For some group members, our credentials and our role within the organization is going to help them feel safer and more trusting of us. But in general, the level of competence and skill that we demonstrate is going to help people feel safe. And of course, the level of empathy and compassion and understanding, passion that we have for our work, the wisdom that we demonstrate, the knowledge that we offer, and our ethics and integrity that we embody all cultivate a sense of safety with the folks we're working with. So I want to pause here and invite you to take a moment to reflect on your own group leadership. And what are some of the things that you could do as a group leader to help participants in your group feel safer and feel more connected?